Okay, welcome back to my channel. This is Dr. Li Ping, Pathology PGY3 resident in Gasinger Medical Center. Let's continue our part 2 of selected soft tissue and bone tumor of head and neck. So the first entity we're going to talk about is aggressive fibromatosis. This is kind of infiltrated the neoplasm with bland spindle cell proliferation forming long vesicle. So we can see this bland spindle cell just forming this long vesicle, and then they kind of infiltrate to the adjacent skeleton muscle. They wrapping this skeleton muscle. Sometimes they will cause some atrophic changes. But high power, we also can see this spindle cell kind of bland looking with this collagen deposition. And characteristic IC staining is beta-catenin, both cytoplasmic and nucleus, seen in 70% to 75% of cases. We have a long differential for different kind of spindle cell neoplasm, including some we already talked about, like solitary fibrous tumor. The next entity is Nuchal-Type Fibroma. Really important clinical finding is that this Nuchal-Type Fibroma is always or almost exclusively found in the posterior neck. And then this spindle cell is CD34 positive and hypocellular neoplasm. And immunostaining, other than CD34, SMA, desmin, and nuclear beta-catenin negative. So this is the MR to show this mass in the posterior neck area. Then the H&E staining, we just can see this really collagenized sclerotic neoplasm, spindle cell, really hypocellular. They can wrap this annexal structure. In this sclerotic background spindle cell, they wrap the nerve. They can also trap the adipocytes. So here's the differential diagnosis for this bland-looking spindle cell neoplasm. The next one we're going to talk about is infantile Fibrosarcoma. So this is a malignancy. Characteristic is this ETV6 NTRK3 fusion. This is a malignancy, but usually just local, aggressive, and rapidly growing, and really rare metastasis. And then when we talk about the soft tissue tumor with translocation, we already know that the cells should be monotonous. So really hypercellular area compared to the SFT. They may all, this entity also have this kind of Staghorn vessel, but this cellularity just makes you distinct from SFT. And also from the clinical feature, this is infantile fibrosarcoma. So usually you will find this disease in a neonatal less than 2 years old. They can also wrap this annexal structure, but really hypercellular, and then also forming kind of long vesicle growth, not like the SFT, we have patternless pattern. And the cell look really similar because they have ETV6 NTRK3 transfusion, but the cellularity is really high. You can also find some mitosis. Necrosis is another characteristic finding for this infantile fibrosarcoma. So immunostaining is not characteristic. If you're suspicious for this entity, you can use pan-track as a screening marker. Then if that is positive, you can do FISH to do 12-15 ETV6 NTRK3 fusion. Here's the differential diagnosis. Of course, synovial sarcoma will be another good mimicker of this infantile fibrosarcoma, but the age not really match. And then you can use this characteristic translocation X18. You also can use really useful immunostaining SS18, SSX to make a diagnosis of synovial sarcoma. So here's a virtual slide for infantile fibrosarcoma. So even in low power, we can see this lesion had a lot of blood vessel. You may suspicious whether this is a nasopharyngeal angiofibroma, but you can see the really hypercellular between this vessel area to make you thinking, oh, that is a funny looking lesion, really hypercellular, not really like angiofibroma. And when you zoom in, you can see tons of cells, and then the cells look quite similar, and then they forming this vesicle growth. They can form this vesicle growth. Even some blood vessel mimicking SFT with this dead horn vessel, but just the cellularity is too high. And then we can go to high power, we can see mitosis. It's not difficult to find some mitosis. And then all the cells look the same, monotonous, because this is the transfusion driven malignancy. By ETV6, NTRK, mitosis. But it seems like in this slide, just this cellularity to make you thinking about something bad, something malignant. Okay, the next one is undifferentiated pleomorphic sarcoma, not otherwise specified. So this is a high-grade pleomorphic malignant neoplasm. I think if you want to make this diagnosis, you need to exclude other common entity. So this is a panel we usually use to make the diagnosis. First, for these pleomorphic high-grade cells in the deep soft tissue or in the ENT area, first thing you need to rule out is melanoma. So you can use SOX10 as 100. And then some epithelial marker. If we want to rule out squamous cell carcinoma, you can use CK56 or AE13. This pan-CK includes some high molecular weight cytoskeleton. And of course, P63 and P40 is a really good nucleus marker to rule out squamous cell. Chem5.2 including other low molecular weight cytoskeleton, so you can rule out some epithelial carcinoma. And then if you want to rule out rhabdomyosarcoma, desmin is a good sensitive marker. And then never forget angiosarcoma. So some people would like to use CD34 to screen for angiosarcoma, but you need to bear in your mind that some epithelial angiosarcoma could be CD34 negative. So other better marker is CD31 and ERK. These two markers is really sensitive for vascular differentiation. So we can see this H&E image really hypercellular, forming this vesicle growth, and all the cells are not the same. Some cell is hyperchromatic, some cell is hypochromatic, really ugly, pleomorphic, high grade looking. And then this nucleus really bizarre. It's really easy to find some mitosis apoptotic, and then pleomorphism is the great feature for this high grade undifferentiated pleomorphic sarcoma. So a lot of differential diagnosis we need to think about. If you are thinking about the differentiated liposarc, you can use MDN2 FISH to make a diagnosis, but really rare you can find the differentiated liposarc in the ENT area. They usually almost always in the retroperitoneum. And the next entity is rhabdomyosarcoma. This is the malignant neoplasm showing skeletal muscle differentiation. and head and neck is the most common area, especially in the nasopharynx area. The second common area is the genitourinary tract. There are several subtypes of rhabdomyosarcoma, including embryonal, alveolar type, pleomorphic, and spindle cell sclerosing rhabdomyosarcoma. Here I just want to talk about alveolar rhabdomyosarcoma because they have some unique feature. I hope after this lecture you can have good enough sense to make diagnosis of this alveolar type rhabdomyosarcoma. So alveolar type, that means they can mimic kind of alveolar in the lung, but the neoplasm is this small round blue cell inside this alveolar-like area. You can see this cohesive of these cells. If you are lucky, you may see this kind of rhabdomyosarcoma cell just mimic this rhabdoid looking, or maybe plasmacytoid, whatever term you want to use. Just this eosinophilic cytoplasm and then eccentric nucleus. So when you see this cell, you really want to use a Desmin to just screen for it. Then the tumor cell itself, just this small round blue cell looking, and some mitosis is not difficult to find. And then, as I mentioned, Desmin is a good sensitive marker for this skeletal muscle differentiation. And more specific marker, you can use MyoD1, myogenin. Then, specific translocation for this entity is T12-13 or translocation 1 and 13. That is the PAX3 FOXO1 or PAX7 FOXO1 translocation. So as I mentioned, the cell look like the same. They are all round blue cell because they have specific translocation. So this is the alveolar rhabdomyosarcoma. In low power, this kind of neoplasm just really blue, and then between this blue necks of cell, you have this pink sclerotic fibrosis collagen or spindle cell looking, just separates this blue area of malignancy cells. So when you low power, you find this feature, you need to suspicious for alveolar rhabdomyosarcoma. Then, of course, you always would like to see alveolar type, but sometimes it's not that classic. One of the hints here is we can see this cohesive population. If you want to see alveolar type, you just zoom in this cohesive area, so you can see they're forming this kind of like alveolar area separated by this fibrous septate, and then the cell is this cohesive small round blue cell in this alveolar mimicker with this small round blue cell, so you can make the diagnosis of alveolar rhabdomyosarcoma, and then flow your immunomarker Desmin, and even using other myogenin, MyoD1 to find this skeletal muscle differentiation, and then use FISH. PAX3 FOXO1, then PAX7 FOXO1. So this is alveolar rhabdomyosarcoma. The next one is teratocarcinoma